Good afternoon. Thank you so much for joining us today. My name is Tamara Bingham. I'm the Director of Business Development here at Center for Change. I'm here with Dr. Reid Robison, who I'll introduce in just a few minutes. We have just a little bit of housekeeping to do before we get started. First, I wanted to say I think we had a couple of folks who were on a little bit early. The webinar starts at noon Mountain Time, and that's what our e-blast says. But I think when GoToWebinar sends the confirmation when you register, it will put it in your time zone. And I think that's based on your device. So if your device maybe wasn't updated for daylight savings time, which Utah transitioned to, it could be that there was a time difference there. So I apologize for those folks who maybe had a different time, and we'll see if we can put some additional information in our future e-blasts that highlight what time it is for the webinar in Utah. So I apologize if there were some issues there. We're so glad you're able to be with us nonetheless. Okay, a couple of housekeeping items really quick. So a copy of the PowerPoint is in the handouts section of the toolbar that you see. You're more than welcome to view that if you want, or download it so that you can look at it later. It's also on our website under the professionals tab. When you click on webinars, you'll see the PowerPoint is there, as is a copy of the post test. So the post test is also, a copy of that is also in the handout section of the toolbar. You can take a look at that as Dr. Robison is presenting, so you'll know the test questions that are going to come up. That's just for reference only. You're welcome to submit questions in the questions section of the toolbar. We have a significant number of you folks on, and we're thrilled about that. It also means that there's just no way we can have you on camera or have your mics on. There's just too many folks. So, but we definitely would love to get your questions throughout. I'll keep an eye on those throughout Dr. Robison's presentation, and then we'll save some time at the end for questions. We likely won't get to all of them, but we'll do our best to get to some of the ones that are more prevalent and maybe that multiple people have asked. We'll try to do that. And then Dr. Robison's contact information is on his last slide. If there's a question that we don't get to and you really need the answer, you can reach out to him directly. When the webinar ends, there will be an evaluation that will automatically pop up on your screen. If you'd be so kind as to fill that out, that would be really helpful. That's a continuing education requirement for us. It's completely anonymous, so feel free to be candid in your feedback. Once we get all of that, we tabulate those results and send those to the CE providers. That's part of our requirement. And then what you all want to know is, how do I take the test and get credit? About an hour after the webinar ends, you will get a separate email from GoToWebinar with the link to take the online test. And you have to take the test online in order to receive continuing education credit. Once you pass the test online, your certificate will automatically be downloaded to your device. So if you don't see it, check your downloads folder. It could be hiding there. Okay, without further ado, I'm so happy to have Dr. Robison here with us. Dr. Reid Robison is a board certified psychiatrist, and he's the medical director here at Center for Change. He also is the chief clinical officer at Numinous, and he is just a wonderful human. I'm going to let Dr. Robison tell you more about his experience and what he does. I can tell you that he's kind and compassionate and really cares about the patients and the clients that he treats, and he does so with the utmost care. And we're really grateful to have him part of the Center for Change family. And so I'm going to turn it over to Dr. Robison. Dr. Robison, I'm going to send this over to you and make you the presenter. And I'm going to hang on till we get that all done, and then I'll pop off. Perfect. There you are. Let's make sure we can hear you.
Okay. Can you hear me okay?
Yes, maybe turn it up just a little bit or a little bit closer to the mic.
Okay, there we go. I'll do a little of both.
That's
How's
perfect.
that?
That's perfect. Thank you. Okay, I'm going to turn off my mic and my camera, but if you need me, I'm right here. Just holler, I'll pop back on. Otherwise, I'll see you at the end of the presentation, and we'll do some questions at that point.
Thanks, Tamara. And thanks for the kind words. I wanted to start with an acknowledgement of the land where I live and work, and how grateful I am to the Indigenous peoples, not just for this land, but for the teachings and the age-old traditions of the medicine work we're starting to draw from and realize more and more, both here in Utah and in far-off places. Early in my career, I used to travel with the Global Health Alliance at the University of Utah to places like refugee camps outside of Burma, rural parts of Africa, etc. And I'm convinced that while I was trying to bring tools and resources to help alleviate suffering in these developing nations, I will admit wholeheartedly that, and humbly, that this realization that I'm convinced I learned much more from these communities than any possible help I may have brought. In fact, I remember a formative experience when I traveled down to the jungle several years ago seeking new treatments for eating disorders. I had volunteered to be a therapist and also the medical support at an intensive retreat that was pairing ceremonial use of ayahuasca, a plant medicine, with the best evidence-based psychotherapies we could bring to the equation. And as a condition of that role I volunteered for, I had to experience it first, which we all did before the retreat. And it was such a transformative experience for me personally and professionally. That isn't the topic of today's discussion, but I'll just share one thing. On a boat ride back from this retreat center, while headed to an airport to fly home, I remember saying to a couple colleagues something like, "Never again will I work with ketamine without ceremony and ritual and without careful and even, dare I say, sacred intention." So, and just an acknowledgement to my teachers and mentors along the way, and all the dear colleagues I've had the honor to collaborate with so far. So I'd like to start with a few thoughts on eating disorders as a window to the struggling soul. There's this saying in the field that we hear sometimes, that it's not about the food, and that resonates with me and represents an important reminder. But someone really, as myself, really trying to integrate both science and spirituality, the mundane and the mystical, if you will, the psychological and the medical, I'd rephrase it as something more like this: it's not just about the food. There is, of course, no substitute for weight restoration, especially when medically compromised, especially for conditions like anorexia that carry, as we know, an alarmingly tragic, scary mortality rate that exceeds nearly all other mental health conditions. And equally, if not more important, if we ignore what's underneath the symptoms, the history for that individual is bound to repeat itself. So part of the work, the way I see it, is to uncover the meaning, the purpose behind the symptoms, and help personalize, individualize the approach with the whole team, using the best evidence-based and innovative modalities that we can bring together to help people heal and grow. So that being said, I know I'm preaching to the choir here, and so fond of and honored to be part of the community of eating disorders professionals. I've learned so much since starting my work several years ago at Center for Change, and from colleagues all across the US and Canada and beyond. But these points I put here have just served as useful reminders for me and for families I work with, and for the broader medical and mental health community at large, especially those who don't work often with individuals with eating disorders. So I find it helpful to have a lens through which to look at these things, other than looking just at the behavior itself, because no one wakes up and says they want to have an eating disorder. Well, on TikTok and other platforms like that, sadly, some people may say that, often in the throes of a struggle, and of course lacking insight, and because this is not how it works. Eating disorders seem to be a perfect storm of both the genetic deck of cards you're born with, perhaps a predisposition to anxiety, OCD, perfectionism, for example, and then the constellation of things that happen throughout an individual's life, whether it's a traumatic event at an especially formative time, whether it's something like early onset of menses and puberty, and things that are even more pervasive, like being part of a community focused on, or a society or community, focus on body shape, size, performance, and how that was handled by, say, coaches and peers. And of course, the society that we are all in with unrealistic beauty ideals, full of misogyny. And by the way, I'll just say here as a male, and through both raising daughters and working with so many women at Center for Change, men not only need to acknowledge and own up to the sexism in society, but also participate in the activism and advocacy. So the history of deeply ingrained systemic sexism that has existed for so long in our culture still exists, and we need to work together collectively across genders on these societal problems that still run rampant, and towards a vision of a more equal society. So I'll end my rant on that for now, but lastly, I want to point out that the things we'll be talking about, ketamine, medicines, specific psychotherapies, are novel approaches to consider that may show some promise and may be a helpful tool in the toolkit. And these are just part of the equation, potentially part of the equation. I firmly believe in the stance that eating disorders are serious, multifaceted conditions that require a multidisciplinary team approach, not just within the treatment teams, but with outside providers and of course, and especially with family members, caregivers, loved ones. So all that being said, one more little tangent. Those who know me know I do a lot of clinical trials. I've been a researcher at heart since pretty early in my training up at the University of Utah. And these days in our research clinics at Numinous, I oversee a number of psychedelic medicine studies, not just with ketamine, but also with classic psychedelics. Like right now, we're doing a study of LSD for anxiety and psilocybin for depression, and eating disorder studies whenever we can, hopefully more and more in the future, because as we all know, these are so desperately needed, and eating disorders are traditionally underfunded, under-recognized, and as we also know, there are no FDA-approved medication treatment options for anorexia. So we're publishing what we can along the way, including like last year, a paper about group ketamine therapy we did at Center for Change that I'll talk a little more about. And even this week, a paper came out in collaboration with Janet Treasure and colleagues in the UK on using ketamine and Spravato for anorexia. And that one didn't make it to the slides because it just hit the press this week. And Tamara, who introduced this and runs this webinar series, not only very well organized, but did me the favor of requiring slides early, so I didn't have to do my usual thing of tinkering with the slide deck into the wee hours of the morning last night. So this slide has an abstract from a paper that isn't about ketamine, but I wanted to draw your attention to it because, interestingly, it's one of the first ever studies using a psychedelic medicine, and one of the first ever studies of using psilocybin, the active component of magic mushrooms, that was done in any hospital or clinic setting. And this happened to be done way back in the 1950s in France. So this paper was a part of a bigger study, nearly 100 individuals, mostly with mental health conditions. And one case stood out that's profiled in this paper. It was a 35-year-old lady by the name of Henriette with anorexia and a BMI of 14.6. When she was first admitted to the hospital, she was put on the psychiatric ward and placed in isolation and put on Thorazine, a sedating old antipsychotic. 3 weeks later, no improvement. While still on Thorazine, she was enrolled in this psilocybin study and given 8 milligrams of psilocybin, a relatively low dose, about a third of the dose we're using in psilocybin studies these days. The studies that are on the path to potential FDA approval of psilocybin for depression. So she gets the medicine. 1 hour later, she says, "I think I'm getting better." They didn't think much of this, the researchers, because she didn't look like she was having much of a psychedelic trip. They assumed because she was on Thorazine, and Thorazine interferes with serotonin receptors that psilocybin works on, They thought nothing was going to happen. They sent her back to her room. She gets back there, was feeling more and more euphoric, felt like dancing, felt light. Said she heard angels playing the flute. She started writing poems and having kind of this inspiration about her life and spirituality. A lot different from her usual place of where she had been feeling disconnected from the world, her emotions, her body, her spirituality. So after she reported this, they took her off Thorazine. 4 days later, gave her another dose of psilocybin. Half an hour later, colors changing. She feels like she's in a cloud, having visions, hears angels playing flutes again. She even takes on this sense of suffering of the world, really connected to her spiritual and religious belief systems, starts to report in vivid detail these old memories that came back to her, such as emotional traumas in her childhood. And then this second dose was followed by some immediate and semi-lasting improvement. A month later, a month after the second dose, she had gained over 15 pounds of weight restoration. Interestingly, if you read the whole paper, you'll see that the improvements didn't last forever, perhaps highlighting a few things. One, that dose matters on medicines. Two, the number of doses is likely important for lasting effects. And three, or what we call set and setting in this work matter. They didn't care about those things back then. They just gave the medicine, shuttled people around to different offices, getting different psychological tests, where most people just felt kind of annoyed and poked and prodded psychologically through that. And then number four, that I draw from this paper is that the therapy paired with these things is important. These medicines can open up a window of opportunity to do some deep therapeutic work, and that's what I'm going to talk about today. So looking at the big picture of this, internal family systems is a form of parts work, and parts work is a type of therapy that sees the self, our whole self as a collection of various parts or sub-personalities. And according to these theories, or through this way of looking at ourselves, psychological disturbances arise when parts are put in conflict with each other, with the core true self, and healing wounded parts involves kind of reframing the relationship between the symphony of selves that exists within each of us. So parts work is actually the foundation for lots of psychotherapy modalities, not just internal family systems, but like ego state therapy, voice dialogue, some types of Gestalt and Jungian archetype analysis. Internal family systems itself was developed by Dick Schwartz in the early 1980s, and he'll tell you, if you hear him speak, especially if you ask him about the origin, that this therapy modality came through his experience in working with eating disorder clients. And the key component of internal family systems is allowing space, like a compassionate space for all parts to be seen and heard and witnessed and accepted, despite how polarized and conflicted they may be or have been in the past. So these are, I guess, what you could call 5 basic assumptions of internal family systems. So that our minds, ourselves, are subdivided into a lot of different parts. An unknown number. Each of us has a capital S self, and this capital S self ideally should be in charge and should be at the head of this table, or should be the driver of the bus, and often is not. And especially when we get activated, when we get triggered, often a triggered part will grab the microphone or grab the steering wheel of the bus and take over. And in internal family systems takes this approach that there are no bad parts. Every part had started out with and has a positive intent for you, no matter how problematic it might show up in a conflicted system that is often beneath the level of our awareness. And personal growth and development leads to kind of the whole family and system growing together. So, and then the last assumption is that we all have inside of us the resources we need. There's this capital S self. There's this inner healer and inner healing intelligence. There's we may not always have access to the wisdom and insight within because of the polarization, you could say, of parts, and similar to external, like real life family issues. This internal family can get locked in conflict, combat, using up all the emotional energy on dramas and arguments and things that could. And part of the work is to, redirect this, welcome them all in, and do some, some conflict resolution, but not exiling parts, but rather, inviting them back in, seeing them, releasing their burden, so the internal family can function as a cohesive team and synergize together. So usually when we first become aware of a part, we will evaluate it. We'll, decide if it's good, embrace it, give it power, give it more of that driver's seat, or sometimes we'll kind of often hastily, reactively decide that it's bad, try to suppress it, get rid of it. But from an internal family systems standpoint, you can't get rid of a part, you can only push it deeper into your subconscious, where, like Carl Jung says in some of his quotes, where it will continue to, direct your life, and you might call it fate, instead of realizing that there's an exile or squashed part that we try to get rid of, but we actually cannot. We can see them, we can love them, we can help them heal, and we can give them new roles. So in IFS, what the approach is to welcome all parts with a curiosity, with a compassion, seek to understand them, appreciate them, and their efforts to help us, even if the efforts at the time were to do something like, control what we could at a time of intense chaos, even trauma, because it may have saved us from something much worse. We may have needed to numb out for a time. We may have needed to behave in certain ways, and then we reevaluate at this point in our life, at this age and stage, and with these resources now. Maybe those behaviors are no longer needed. Maybe they're outdated, and this is what is meant by like giving a part a new role. Helping see and understand them, and helping them release their burdens, and take on a new task of helping us show up in the best way for us at this time. So the work involves developing a relationship, getting in relationship with our parts, and then helping them release burdens so we can all function together in a healthy way. In the IFS model, there are two types of parts, protector parts and exiles. So the protector parts are the ones we first often run into when doing this work, because their job is to, handle the world and protect us against deep pain. And then the other type of parts is like the exile part, or often from earlier in life, parts that hold pain from the past, and sometimes they're held in like a mental prison, but they want to be heard, they want to be seen, they want their story to be told to, the capital S self, to the other parts, but and so that becomes part of the work as well. So as an example that I put up here, hypothetical client named Sally has a part that says, you can't be successful at your ambitious goals. Who do you think you are? And this, of course, gets in the way of her taking action in her life. And then as she starts to work on, from a parts work perspective, she sees that that was actually a part trying to protect her from the pain of failure. The pain of getting punished if she tried to assert herself from earlier in life. So Sally had a protector saying this thing, who do you think you are? And that message got in the way of, fully embodying her capital S self in the way she wanted. Turns out that this client example had been, punished at a strict Catholic school whenever she became too visible, and then developed and deepened this kind of pain and fear of that tried to help her stay invisible. Okay, let's see here. There we go. With eating disorders, from a parts work perspective, there can be what you could call extreme polarizations between parts. This is also the case in working with substance use disorders. So these parts, there are two kinds of protectors. There are managers that kind of keep us busy, might keep us from sitting still, keep us doing things. They might manage our lives in a certain way to avoid the pain, but there are also these firefighter parts that will bust out a fire hose and react in a big or dramatic way to keep us away from feeling the pain. Like there's this saying I like in therapy that if it's hysterical, it's historical. If a big reaction we have is out of proportion to the situation, it's likely tied to some internal mechanism of vulnerability, some past wound. In the same vein, you could say, what's in the way is the way, or triggers show us the path, or these obstacles show us the path, they show us our work. So we start often in IFS for eating disorders with the part that is that repulsed by the eating disorder as kind of a trailhead. And sometimes we need to be we need to bring hope until we can get the system on board with that, be a harbinger of hope to these protector parts, often who are repulsed by the eating disorder, for example. So parts take on extreme roles sometimes because of what happened in the past. We talked about the managers as types of protectors, but the firefighters, in order to protect from this pain, brought more of an impulsive response. And this could look like, binging or substance use or, intense reactive conflict with others. And all of these protectors, managers, firefighters, protecting from feeling pain, protecting the exiles, which may have some pain related to trauma, for example, locked in there. And the protectors just keep us going through all that until we have the time and space to heal and integrate the system in a new way. And internal family systems as an approach is pretty practical. I like that it's full of these nice, clear foundations and assumptions, and even acronyms and lists like the 8 C's of self, that capital S self that is the goal of stepping into. The capital S self that sees all the parts and welcomes them with compassion and curiosity. And this is probably one of the more helpful lists in whatever kind of therapy you do, because if you can identify some of these as clues to who's in the driver's seat with your client at a given moment, or if you can try these on yourself and ask yourself if you're feeling calmness in a certain situation. Are you feeling compassion to self and others? Do you have any clarity? Do you have confidence in the path forward? creativity, curiosity, things like that come on board when the capital S self is front and center. And the capital S self, as we've mentioned, is the chief, it should be the chief agent of the inner family. So I wanted to, take a risk here on just explaining something I've seen over the years is there's this beautiful work by Jenny Schaefer, in the form of multiple books that many clients and families with eating disorders read and find quite helpful. But I think there's a risk of taking this towards an approach of exiling, getting rid of parts, because I do believe, as is taught by the IFS model, that we can't really get rid of a part, but we can get rid of their burdens. So and I'm just presenting all of this for you to consider and try on yourself and with your clients. What would this approach look like if there were a stance that there are no bad parts? Like, what would happen if we befriend the parts and learn to relate with them? Knowing that befriending the part does not mean agreeing with its methods or doing its behaviors. Befriending the part also doesn't mean we're waging a war against it. It's a stance of compassion, understanding. It means we've got to feel the unfelt feelings. You got to feel it to heal it. You need to shed the unshed tears. You need to go back to these past wounds and acknowledge them, accept them, and figure out the path forward, and know that these parts that we might really despise in ourselves, that get us into trouble, get us into patterns of behavior, are ones to approach with love and compassion and understanding, rather than waging a war of conflict that in my opinion just makes things worse, or is not a lasting sustainable change. So unburdening, I mentioned this earlier. So this is the process of releasing the extreme emotions and the beliefs that the parts have been carrying. So, and in eating disorder work, this can look like a few different things. Remember when I went out to this ayahuasca intensive retreat in the jungle, and there were a bunch of us as therapists and mental health professionals, a lot of kind of eating disorder experience as well. And then there was the medicine team that brought the traditional plant medicines and the ceremony and the songs and the practices that we were all bringing together. And something struck me when I realized that the way the shamans and the indigenous people would talk about the ancestral suffering or the burdens that are passed along, sometimes even calling them like an evil spirit or something like that, we kind of all realized that we were speaking the same language, and that we, through whatever mechanism, and probably many mechanisms, the things that we pass on through the generations related to society, to family specific conditioning, can be looked at through a lot of different lenses, depending on culture and the community we're talking about. But in the end, it is about recognizing these maladaptive patterns that have been passed along for whatever reason and whatever ways, and interrupting those patterns and inserting a more adaptive and positive way of showing up, of raising kids, of interacting with each other, of showing up in society, of approaching things like diet culture, beauty. We talked about misogyny, sexism, and the unburdening can also work on the attachment wounds and traumas, whether they're from early in life or or show up later. And so this is a quote from an IFS therapist who has some eating disorder expertise. After asking what brought a client to treatment, I asked what their part that wants to restrict binge says about being here. Recognition of the firefighter's existence, firefighter being a protector part that reacts often in an extreme or dramatic way, like, say, initiating a severe stance of restricting or an episode of binging. So recognition of its existence and the invitation for it to speak is both a profound and a beautiful moment, and is also the first step in befriending that part. So I put this quote up here because it really, I think, shows in a clear and simple way what the work kind of looks like and feels like of seeing and befriending these parts. And so there is a book out there called An Internal Family Systems Guide to Recovery from Eating Disorders, Healing Part by Part, by Amy Yandel Grabowski, and it's also on Audible, and I think it does a great job at looking at these parts from an eating disorder perspective. And I'll show you this slide, then we'll go back to the last. This would be the self-led system, capital S self, as the chief agent in charge of the inner system. When there are those 8 C's we were talking about in the self circle. And these other parts that might be your inner child that can be playful and fun and have a sense of humor and sense of awe and wonder, as opposed to when it is exiled or locked in a state of fear, pain, or anxious or fearful about the world. The part in a kind of a self-led system in balance that might be an advocate or assertive, protective, saying no to things in favor of, the self-care that's needed to fill our cups before we, drain it on all the things the world might be asking of us, as opposed to, that same part or collection or category of parts when out of balance, without the shining the light of awareness on it and doing some healing work, might show up like a defiant or rebellious or oppositional part, or a why bother part, or one that just keeps distracting and sidetracking from the task at hand. And then the other circle, the mentor circle, in a system imbalance that might motivate, organize, solve problem, plans for the future when out of balance, when the capital S self is not in charge, might look more like a bully towards self, self-critical, judgmental, harsh, punitive, perfectionistic, both internally, externally critical, loud, angry. And instead of the self, that capital S self stepping in, there might be a sense of feeling empty or hollow or lost or lacking in identity or direction. And so this is what it looks like on the continuum from when parts are leading the system and have the driver's seat or the mic. The rebellious parts might be, acting defiantly or just giving up, and the distracting parts might be diverting, sidetracking from doing the work, numbing parts, etc. So let's look at some IFS studies, and with the disclaimer that there are not countless studies to report on yet, and more research is needed. There's been a lot of enthusiasm and kind of anecdotal success of IFS as a model lately, and a lot of studies in the works showing some exciting things. I wanted to highlight what is out there, and encourage us as a field to keep both trying on promising, innovative things, and also kind of applying good, sound scientific reason and generating collectively the evidence that's needed to know what and how to use for the good of our clients. But this is an interesting study of IFS for survivors of childhood trauma, where 17 people with PTSD and multiple childhood traumas came into this study. They got 16 90-minute IFS sessions. And point that out because this is, a therapy-intensive process, and they're not, doesn't pretend to be a magic bullet cure for things rather quickly. So there were 4 evaluations through this study, and CAPS 5 total score on the chart is the trauma score, like a self-report measure of PTSD that we use in a lot of our studies with ketamine and other medicines too. So there were significant decreases over the course of the study at these evaluation periods in PTSD, in depression, and these were quite statistically significant, providing some support for IFS as a promising modality to consider for healing childhood trauma. There's another study, not published yet, but published on the IFS Institute's website, that enrolled a little over a dozen people with PTSD, did 16 sessions. This is PTSD and other conditions, and only one participant still qualified for a diagnosis of PTSD at the end of the study. Huge effect size on this small study, albeit. So it needs to be, of course, replicated in a bigger way, but there were significant decreases in depression, affective dysregulation, dissociation, improved relationships, and ways of attaching meaning to things in their life. All right, finally on to ketamine. Like, how does this relate? I'm going to skip some of the history of ketamine. You can download the slides and look at some of this, but I want to make sure we have some time for questions. But first of all, a few ways that we think ketamine works. It blocks NMDA receptors. As such, it's a glutamatergic medicine, and by restoring glutamate signaling or glutamate tone, or it's like you're kind of letting the pathways communicate more freely again in the brain that might have been stuck. Let's see here. Another way it works is by turning off what's called lateral habenular burst mode. You don't hear about the little lateral habenula in the back of the brain. There's this place that's like the anti-reward center. It can get in an overactive state or stuck in hyperdrive from the stress of the world. And like when ketamine comes along, for many people, it feels like a weight is lifted. It's a rapid antidepressant over countless studies, and it may be in part from this mechanism, like you're taking a fire extinguisher to this lateral habenula area that's on fire, and at least for a time, a week or two perhaps, giving a sense of significant relief, allowing one to do more active therapeutic work. Ketamine can also facilitate the formation of new neuron connections and pathways, neurons that fire together, wire together, and giving ketamine and giving classic psychedelics. Giving ketamine is like putting some fertilizer on this neuronal malleability, the ability to form new pathways, really important in conditions that are stuck in rigid patterns. And then ketamine also is described by people as feeling like a timeout from the ordinary mind, from overthinking, from self-criticism, from rumination. I've heard this from a lot of individuals with eating disorders who I've worked with using ketamine, that they felt like it was such an important break from the usual inner dialogue. And I just put this mechanism up because it is kind of like through this limbic cortical interruption. It's kind of like you're rebooting the system that has way too many tabs and browsers and apps open, and might be stuck in these loops. So you can have some time and space, and from that, at least temporarily, again, to do the work. And the theme here is that, ketamine is a tool that helps people, helps not everyone, but it can be helpful for many people to get unstuck, to see from another perspective, to facilitate some change, some access to parts of ourselves that might have been difficult. And I'll go back to these three categories of how at least we use ketamine in clinics, in numinous clinics. One is as a psychedelic, where people come in, often get an injection of ketamine. It might be an IV, might be IM injection, eye shades, headphones. They set an intention beforehand. They're kind of supported, monitored through that journey. Not much active guiding because it's an inward journey, and then some processing after and coming in for like an integration session the next day. So that's probably one of the most common ways we use it. Another way you could call psycholytic, which means mind loosening. A low dose of ketamine before going into a therapy session can help some clients open up more. It can help them access parts of themselves that might be too walled off or feel too overwhelming. Ketamine does help put a little bit of distance between an individual and some of the most difficult things, like their traumas or past wounds. Because it's a dissociative psychedelic anesthetic type medicine, and this can be quite useful in the therapeutic work. And then the last way of using it, ketamine, and especially Spravato, S-ketamine, have been found across multiple studies to be rapid antidepressants. So they can be useful even as a medicine alone, in the right way, in a clinic, with all of the other mental health support surrounding it, to help someone feel better quickly in a time of like serious crisis, depression, suicidality, and all this with the disclaimer that ketamine is also a drug of abuse in most parts of the world, and can be abused, misused. And I'm a firm believer in using these things carefully, appropriately, wisely, judiciously, and making sure there's all the screening, evaluation beforehand, the contraindications in mind, and checking in every step of the way of if this is helpful, and making sure that there's a right relationship with the substance. So let's talk a little bit about how ketamine-assisted therapy in general works. There are ideally preparation sessions, including both the screening and evaluation, and getting ready for the medicine, getting to know what it's going to be like, tools and how to navigate it, breath and mindfulness, and leaning in with curiosity. And then on the dosing day, as I mentioned in the psychedelic category there, an individual often really firms up their intention, is supported, monitored during the dosing session, and there may be some processing that happens during, after, but where the rubber and the magic really meets the road is in the integration. What happens next? It's one thing to feel peace, bliss, to have an experience of embodiment during the dosing session. That's great, but the real question is, how does it change how we feel and see ourselves and show up in day-to-day life? And that's where the real work lies, and why I'm presenting to us here for consideration, parts work as a way of approaching that integration, of taking the insights, the perspective that's gained during a dosing session, and applying it in the real world, in the face of triggers, in the face of patterns. Here's I'll let you look at this on your own as well, but a summary of studies on ketamine for eating disorders, including the first one that was done back in the late 90s, one of the earlier ketamine studies, actually. And this is the study that we published last year about group ketamine work that was done as a pilot at Center for Change that was quite positive, showing that through the course of 4 doses, depression scores went down, anxiety scores went down. In the paper, we also report on some meaningful anecdotes, like this individual who said, trying ketamine let me see the possibility of a life I could have. And I thought this was a really thoughtful comment because the person said, well, the effects didn't last. Like, that's known about ketamine. It creates a non-ordinary state of consciousness for a time and creates some effects for a time, like neuroplasticity, antidepressant effects, maybe a little break from rumination. While the effects didn't necessarily last forever, my first experience snapped me out of a state of lifelong deep disconnection that I didn't even know I'd been experiencing. Suddenly I was able to live in the world the way people always described it. So I'm still trying to figure out how to attain that level of connection after catching a glimpse. That one experience was so essential. I could finally feel hunger and fullness cues. I felt like what it's like to live in a body instead of living a distance from it. I felt connected to others, cared about their well-being, felt human for the first time in a long time. And so I'm going to skip over to this and then open it up to questions. But we've talked about parts work, we've talked about ketamine and ketamine-assisted therapy. And doing parts work, in my opinion, early in the process gives clients a framework for understanding what may come up, for looking at their triggers, their activations, their patterns and behaviors in a new way, and seeing the nature of those with a more compassionate lens can help dampen some of this inner critic that can really become so rampant and loud inside our heads. And so pairing ketamine with parts work, where you have the medicine as a catalyst and parts work as the process, can increase awareness of the system and the self, and the returning to wholeness as the goal. So along those same lines, it's okay to examine the quote unquote good things that the eating disorder did for the individual at that time, and that we may be still holding on to, like seeing it as a way of numbing out or a way to manage and the stress, the chaos of life, or having it as a solution for controlling what one felt needed to be controlled at the time. Acknowledging these can be like half the battle in some of this work, that awareness as a great change agent for moving forward. And this is work I thought was really useful from, again, from Janet Treasure and colleagues about the interpersonal and the interpersonal factors that go into maintaining the symptoms and behaviors and condition of anorexia. And I'll leave that for you to explore more in the slides, because I want to leave time for questions. But again, just planting a seed as well for the role of identity. I remember Michael Barrett gave a beautiful talk on one of these webinar series, and at a conference I was at several years ago about reclaiming identity in trauma work and in eating disorders. And that recovery process involves looking at and perhaps even reframing our perspective of how we see ourselves, through a lens of curiosity at first, moving towards compassion and acceptance and a little more calmness, perhaps, on this journey to self-love that people often talk about as an instant ideal to embody, but is not that easy, and sometimes starts with a little step of curiosity. And as such, we help people kind of look for new ways of looking at oneself and new ways of showing up in the world and meaning that can come from a sense of purpose. So just a reminder on this IFS approach, that is one of no bad parts. And I'll read a Dick Schwartz quote here that says, perhaps paradoxically, IFS therapists find that the more clients accept those parts, the more they change. In fact, in many cases, it is the lack of acceptance in the form of striving for change that becomes the biggest obstacle, meaning de-identification with the eating disorder, or conceptualizing the recovery as a battle where you have to divorce or kill off Ed. Well, I'll admit it can be helpful with the right other forces at play. There's a risk there. I'd like to just point out that it can be distressing to kill off a part of oneself, to try to, when this has been woven so much into the fabric of our sense of self and showed up at a time for a reason. And so in this light, we go for a new role for the parts and ask them things like, to the protectors, of all the things you could do in the system, what would you do instead of like reacting in this way of binging, for example, or fixing something. And this allows us to start to shift to roles that are best for the whole system and move towards this capital S self. So I talked about the need to try these tools on, if they are tried on, in this multidisciplinary team approach, and the importance of keeping the medical and safety screening before considering either ketamine or novel therapy tools, and making sure the foundational aspects are there. But I will say that in my experience, I've witnessed time and time again the powerful healing and growth and self-awareness that can come from trying on an approach like this, medicine plus therapy for someone who's a good candidate who may have felt stuck in a revolving door of trying things that haven't worked for them fully thus far. And so I hope that we can continue to explore these together and collaborate and figure out the best ways to approach therapy with these medicines that are coming into our system at a much needed time. Well, I'll just leave it there. Thank you for listening. Looking forward to taking a couple questions.
Thanks, Dr. Robison. I was just going to say, will you move your slide forward, and you beat me to it. Perfect. So folks can see your email address there if they have questions. I'll say a couple of things before we dive in. First of all, my apologies to all of you who I could not respond to fast enough. The questions are coming in so rapidly, I couldn't even quickly type, thank you for your question. So I apologize for those of you that I wasn't able to express my gratitude, because we really do appreciate it. We have a ton of questions, and we won't be able to get to all of them. We'll try to get to some. We will likely, given the time, we'll likely go over time a bit. And I know that there are those of you who have to hop off at the top of the hour because you have clients. So I want to do two quick reminders before you go. The first reminder is that when I do end the webinar, an evaluation will automatically pop up on your screen. If you'd be so kind as to take a few minutes, really for like 45 seconds, to complete that evaluation, that would be really helpful for us. That's a CE continuing education requirement for us from the CE providers. It's completely anonymous, so feel free to be candid in your feedback. We'll tabulate those results and send those back to the CE entities as they request. And then about an hour after the webinar ends, you'll receive a separate email. It will come from GoToWebinar, just like your confirmation email did, so it will look similar to that. And in that email will be the link to take the online test. You must take the online version in order to receive continuing education credit. Once you pass the test, that CE certificate will automatically be downloaded to your computer or your device. So if you don't see it on your screen, check your downloads folder. All right, Dr. Robison, hang on. Let me get back up to kind of, there were some questions near around the middle that were more about the parts work. And then there are lots of questions about the ketamine piece. So let me get there, so hang tight. Take me just a second. was there a minute ago, I promise. Oh, here it is. Okay. This is from Samantha. Samantha says, can you provide examples of burdens the eating disorder part carries that we can work on unburdening in therapy? Some specific examples would be beneficial.
Yeah, thank you for that. Really good question. And
Yeah.
I'm just going to share the first thing that comes to mind. But as a, let's say, for some reason, I'm remembering the book that, you know, many of us have read in the therapy world, Four Agreements, where there's a story of a little kid who loves to sing and is singing, 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 and the mom who was working multiple jobs and at the threshold of her stress level just says to the kid when she's singing this beautiful, loud, say Disney song or something, like, shut up, your voice is awful. And that locked in this change, this burden of like, oh no, you know, my voice is awful, I sound awful, I cannot take up space to be seen and use it in the world. And then tragically went years without ever singing again. And the burden that all this that I've just been describing would be releasing that, seeing it for what it is, and also accepting the fact that of course we stopped singing at that time, and of course mom couldn't handle the stress from because of what she was carrying, and I want to sing, it's beautiful to sing, and let's release those burdens and move forward using our voice. Just I hope that's a helpful example. I know it's not necessarily an eating disorder one, but kind of relevant.
Thank you. Okay, the next question I'm going to combine in two because I think they're similar or go together. So Elizabeth says, I've had several clients participate in ketamine therapy. What I've noticed is it isn't very long lasting in its benefits. Can you speak to that a bit? And then the other question that kind of goes along with that, I think, is how do you feel ketamine compares to other psychedelics, such as psilocybin, in terms of effectiveness? So I think there's some,
Okay.
and there were several other questions about length, duration of the positive effects, and effectiveness.
Yeah,
And
let me
Alexis
start with the
asked the
psilocybin.
second question. I'm sorry, I wanted
Okay.
to shout out Alexis asked the second question about comparing psychedelics to psilocybin, et cetera, and effectiveness.
Yeah, thanks to you both, and very good questions. I'll start with the psilocybin part of it because, just because. So psilocybin initially was in this modern era, like by folks like Roland Griffiths at Hopkins, was studied for things like end-of-life anxiety, people with a serious illness, diagnosis of cancer, let's say, late stage, and who had an intense fear of dying, preventing them from living out the last chapter of their life in peace and presence. And so one dose of psilocybin with the right set and setting and the right therapy was enough to get rid of for many that anxiety that had a specific kind of focus, and you know, comes from a core fear we may all have, even if we don't know it, of, you know, fear of dying or being incapacitated and losing loved ones and existential dread and all that. But the anorexia studies with psilocybin, so the depression studies are looking at 1, 2, maybe 3 doses spread out over a few weeks each, between each, lots of therapy, and that's like major depressive disorder, especially treatment-resistant depression, is you know, proving to be more difficult to treat with just one session, let's say, because it's complex and often multifaceted. And eating disorders are not only perhaps even more complex and multifaceted, but more deeply ingrained and more of a rigidity, generally speaking. So especially when you're talking about something like anorexia with comorbid OCD. So the studies being done with psilocybin for anorexia, while they're looking at 3 doses of psilocybin, usually, say 2 or 3, they're starting to realize from the data that has come in that may not be enough. And psilocybin is different from ketamine in that it's 2 things I'll point out. One is that because of its serotonergic mechanism, it comes with more built-in insight. Like as therapists, we can a little more get out of the way of the medicine and trust the inner healing intelligence, the capital S self, to emerge. Ketamine is a non-classic psychedelic, but a very useful one that doesn't last long, is legal and accessible, and has antidepressant activities, and doesn't require a whole day in clinic. Ketamine doesn't, in my opinion, come with as many built-in insights. It does for some, but as I'm talking about across thousands of people, in my experience with ketamine and in many studies and like overseas retreat experiences with psilocybin. Psilocybin has more of that built in. With ketamine, we have to work a little more, but they both have kind of different mechanisms, different uses. And ketamine, even if psilocybin and MDMA are widely available in clinic, will still have a role, in my opinion. And the other question pointed out that, yeah, some clients feel better and it doesn't last. And that's one of the things with ketamine. Like a single dose of it for most people has antidepressant effects, anti-anxiety effects, and other potential benefits within hours, but may only last days or a couple weeks. We see that if we do a few sessions, like 3 to 6 over 2 or 3 weeks for someone with severe depression, they might have weeks or months of benefit. It might be enough to get them out of an episode, it might not. We've seen some clients have to settle into a maintenance period, like coming in once a month for ketamine, to maintain the antidepressant effects. Some people every couple weeks. And it does represent an accessibility and cost challenge for some people. We're also having success with insurance coverage and Spravato being another option. So kind of a long-winded answer, but really good point, thoughtful question, and they are very different approaches, but useful tools in their own right.
Thank you. The next question is from Brooke, and it's really about kind of the logistics side of things, and hoping that you can maybe give some guidance on that. Here's what Brooke is asking. I'm a certified IFS therapist who works in private practice with eating disorders. Is it possible for me to support clients with integration sessions who are receiving ketamine infusions at clinics, or do I have to work directly for the clinic?
No, I think that's a great point. I'm glad you brought it up because so in the clinics that I co-founded in Utah called Cedar Psychiatry, that are now a part of Numinous, and that I oversee, when clients come in for ketamine, we want them to have a therapist. The therapist doesn't have to be in clinic. In fact, we don't have enough therapists to do the therapy for our clients, period, like ketamine or not, and refer out many people every day. But the more that this kind of psychedelic assisted psychotherapy work is out there in training, and we even have trainings at Numinous on this, and there are lots of good organizations, and the more this is out there, the more people get familiar and comfortable with the pairing of these things, the more we have this network of clinicians to support clients going through this kind of experience, whether they're going off to a psilocybin retreat in Jamaica or they're going to a ketamine clinic down the road for ketamine. I think that's a great approach, is to be the therapist for them, helping them integrate. And it's way better if you know the client and if you know eating disorders, to help support a client with eating disorders through that process. And so that's how we do a lot of the work at Center for Change as well. It's a collaborative process where clients may come out to an outside clinic, like one of the Cedar clinics by Numinous, for a dose and do their therapy work inside the center and in a collaborative way.
Right, thank you. We are way out of time, but I want to end on a comment as opposed to a question, a comment from Tanya. Tanya said, I wanted to say thank you so much for this training. So much great information. I just completed a course to facilitate psilocybin treatment in Oregon, and this really resonates with me. So I wanted
Thank
to
you
let
and
folks,
congrats. Yeah.
sorry, go ahead.
Oh, that's exciting times in Oregon. Thanks for speaking up.
Great. Thank you. Thank you, Dr. Robison, for an amazing presentation. Thanks to everybody for all the great questions. And I'm sorry we couldn't get to all of them. Again, if you would like to reach out to Dr. Robison directly, his email is on that last slide. And thank you all for joining us today. It's been a delight to have everybody with us. Please stay well and take good care, and we'll see you next time. Bye-bye.
Bye. Thank you.